Thank you for joining us for LARA Live. I am here with Dr. Peter Graham from Sparrow in Lansing, and my name is Kim Gatica. I'm the Deputy Director for Licensing and Regulatory Affairs. And we are here today to discuss MAPS and several of the new opioid legislation that's been enacted, and some of the bills are going to be in effect July 1 of this year, and several of them have already gone into effect this year. And so if you have specific questions, please put them in the comments below for those of you who are joining us here with us today, and we will try to address them as soon as we can. So let's just start this whole conversation about maybe some of your experiences with MAPS. As you know, we replaced the entire system, and MAPS being the Michigan Automated Prescription System, and you're a physician, and maybe you could share with us some of your experiences, and then we can start going into maybe any questions that you might have with some of the new laws that have taken effect.
Sure, and I'll try to reflect some of the questions I've heard from my colleagues, which I think are important. I've been in practice 20 odd years, so it creeps up in a hurry. I'm old enough to remember the previous MAPS. I think most of us are, so the new iteration has been a welcome change. And I know we've had, I say, you'll probably be glad to hear that. And not to throw shade at whoever developed the previous MAPS. I'm sure back in the mid-90s when it was created, it was state-of-the-art, cutting edge, and all the rest. Unfortunately, it was very clunky. The sign-on was not easy. Trying to get your login credentials is not an easy process. The Apparis-backed map system has a really easy touch feel to it. It feels like most of the other web-based interfaces that most of us are used to. If you paid your credit card bill online, you can handle maps. It's pretty easy. The only issue with it, and it's not really, and actually this is a both good and bad thing. Maps, the newer maps, much quicker. So searches pretty much instantaneous. We're able to batch searches. We're able to look at different parameters. Also nice to have out-of-state fill data, which is really helpful to us. Particularly any of our colleagues who are in border areas like Benton Harbor or Iron Mountain or someplace where they're by a state border. The only drawback at this point, I think the good news with Apparis is they're a big enough outfit, have enough footprint that they're able to work with EMR vendors to integrate it into EMR flow, which is already starting to happen. It might not be as easy if you're in solo practice or single practice, but for those of us who have the right kind of support and the right type of EMR, they're in the process of integrating those into EMR flows. That's when it really becomes most usable. Because you don't have to essentially go from page to page or out of application to do something else. And also, I would love to see the day when there's a app-based, like smartphone or Android-based app. So I'm hoping some bright young person at Apparis is working on that. That would be a really nice thing to have.
Yes, we are working with Apparis, and that is, I think, one of the technology solutions that you'll see coming down the road here and on the roadmap. And so this is great feedback to hear that the new system is working well. And just as you know, Sparrow has also submitted their information and is in line to integrate their system with MAPS. So we're hopeful to get that done before the end of the year for Sparrow. So
I'm looking forward to it. The other things I would say, though, there's the instrument itself, which is I think very usable and fairly usable, user-friendly, especially in comparison to what was there previously. There's still some I would categorize it as ambiguity among my prescriber colleagues about what the new laws mean, particularly around how often, how frequently do you run MAPS? What is the requirement that changed on the first of the month? So any clarity on that would be helpful. Is this something you have to do every single time you're in an opioid, or change a dose, or a fill happens, or what?
So the Checking of MAPS, Public Act 248 of 2017 requires that a prescriber, before prescribing or dispensing a Schedule 2 to 5 controlled substance that exceeds a 3-day supply, that they would need to run a MAPS report and review that information prior to prescribing. And so in terms of the frequency, it would be, in essence, before you prescribe that particular drug. And when it comes to refills, for example, and a lot of times what a practitioner will do is they might say, I'm going to give you a 30-day supply or a 90-day supply, so basically 30 days and then 2 30-day refills. And so what we have stated in our frequently asked questions with these new laws is that you could prescribe an opiate or controlled substance with a do not fill date. But what gets tracked in our system is not the fill date, but actually the when the prescription was written, the original prescription. Okay. Correct. So in that regard, the prescriber would not have to check it every 30 days, for example. It would be that one time on the front end.
Okay, that's very helpful. I know there's been a lot of concern about that. Same with the informed consent process. I know we're talking about MAPS, but the same type of ambiguity. You know, do I need to do this every single time a patient comes in for, say, just a recheck or refill on something they've been taking for years? Do I need to do that in that context?
So in that context, no, unless you were to, so say you were seeing a chronic pain patient for years and you've kept them on the same opiate throughout the years, the only time that you would need to fill out that start talking form or consent form under PA 246 of 2017 would be to, if you all of a sudden decide to change the opiate. So they've been on the same opiate for the last several years, and you decide as their physician, let's try something else because I'm seeing that your quality of life and your functionality isn't.
Let me clarify. I'm sorry to interrupt, but by change opiate, do we mean change dose or change particular agent?
Very good question. It would be the change in agent.
Okay.
So it'd be the change in the drug. So
okay.
And not the dosage. So dosage changes. It's the same drug, but you're either maybe increasing it, decreasing it based on the medical need of that patient. So
okay.
And in that type of example, you would not need to have a new form completed.
Okay.
I think the other piece that is important to clarify is that the law took effect on June 1 of this year, and we've gotten a lot of questions to the department from practitioners that do I need to have all my chronic pain patients come in June 1
yeah, I've heard the same question,
and
right?
have them sign? No, you would not need to do that. It's not retroactive. So it's just moving forward June 1 and then moving forward, and only if you were to change their opiate and again, the agent versus dosage. So,
okay, that's really helpful. And that brings me to, or reminds me of another source of, I think, angst for a lot of my fellow prescribers and folks who are trying to make sure they're in compliance with this. On the one hand, what are the consequences? And I know that's kind of an unanswerable, having been on this side of the fence from time to time. And what is really the intent? What is the department trying to accomplish, and what was the legislature trying to accomplish? So, I'd start with the premise that most docs, 99.999%, absolutely want to stay within compliance with the law. That is not even a question. They want to also do the right thing for their patients. So they're trying to figure out, how do we do this safely, sanely? So put you on the spot a little bit. I mean, what does that look like from your point of view?
Okay.
And I can maybe talk about that a tiny bit too. But
no, that's fine. That's and I actually appreciate that question. And obviously with your experience having been the former chair of our Board of Medicine, and so you understand sort of the regulatory side and the department's mission and the board's mission to protect the health welfare of the public and our patients and citizens across the state. So I'm not surprised by that question. That's to be expected, but really the intent, and I think I'll go back to more of the legislative intent of that Start Talking form, was to provide at a provider and prescriber level opiate education to their patients. I think one of the things that I heard quite a bit in a committee during public testimony and talking with our legislative partners as we were working through all of these bills in the package that got signed was the concern that so many parents and families and children and adults that were being prescribed an opiate, particularly, I think a good example would be a football athlete that gets injured, and they go see their doctor and or they go to the hospital, either place, and they get treated, and they're sent home with 30 pills of Vicodin, but with no understanding of the risks involved in taking an opiate, and of risks of addiction, of what signs to look for of possible addiction, like withdrawal symptoms, and just how quickly that they can be impacted by that. And so a lot of it was just a lot of families just felt like they weren't even aware of the risks. And so that was really the intent, was for the prescribers to provide that education that was somewhat missing. And so from LARA's perspective, the way we're looking at it is was the education provided when prior to prescribing that opiate? And one of the requirements with that Start Talking form is to put it in the medical record. And now there are some exemptions for minors, for example, if it's an emergency situation, if it's associated with surgery, or they're inpatient, outpatient, and so there are some exemptions from that. And then for the adults, if they're receiving treatment and the opiate for inpatient administration, for example, where it's being administered by a health professional within the facility, there wouldn't be that need for that form.
Right. I think those are all really, really helpful. The informed consent part of it has really been interesting to me in that conversation with my colleagues over the last 6-12 months, really, as we kind of ramp up for this. And part of what I try to remind folks of, look, we've done informed consent as part of appropriate practice of prescribing everything. I mean, you really should think about that. Our patients are really looking to us not just to write a prescription and shove it at them and walk out the door, or these days hit the send button on the EMR and walk out the door, but to have a conversation with them about what is this intended to do, what are the positive effects potentially, what are the side effects, what to look for, what to be worried about. And I would assume that most, and again, having seen this on the regulatory end, most practitioners really do. And if we look at standard of care, we typically do have a conversation with our patients. All this is doing is documenting it.
Correct.
And even prior to, this is just kind of editorializing a little bit on my part, but even prior to the most recent public act, really was an expectation of the standard of practice that LARA and the board had promulgated, that you would be doing informed consent and documenting that in some way, shape, or form anyways. So really all that Start Talking does is give you a standardized form to use, and in some ways makes it a little simpler. I mean, I know it's kind of glass half full kind of look at it, but I think it really does make things a little easier for practitioners. So I hope that context comes across as people get used to using it. It's really just more about the how often. I think that was really more the ambiguity.
Right.
Do I need to do this? And I'm glad you brought up the inpatient side of it. I know that created a tremendous amount of heartburn. Particularly colleagues of mine who work in the emergency department, like, gosh, am I going to have to check this every time? It's like, well, no, somebody goes through the windshield of their car, take care of it. It's like, don't stop and check maps. Do what you need to do.
Exactly.
Absolutely.
Yeah. So that's true for the Start Talking form for the adult patients within the law, and we I think have had to put some further clarity, or may have to do so, because in the Start Talking form under the adult patients, it does say for inpatient administration. And so it doesn't clearly state that for the minor, which is a little bit odd. Okay. So what we've tried to take the approach that there are specific exemptions for the minor, and that typically when you're talking about administration of a drug for inpatient use, a lot of times it's not prescribing; it's actually ordering. So we did
a distinction, but a meaningful one.
We did provide that clarity in reference that if they're ordering or administering, in whether it's dealing with the Start Talking form, and then as well as for MAPS, the same thing. So we did clarify, because the MAPS provision, or the MAPS check provision, I should say, under PA 248, it does reference the exemption if you're in a hospital or freestanding surgical outpatient facility, so a surgical center, for example, facility licensed under Article 17. And so it provides the exemption from having to check MAPs. So again, we just added the clarity about if you're ordering a drug for inpatient use and administration, that you wouldn't have to do that, because in those instances, if you were to check MAPs for inpatient administration, none of that's reported to the system anyway, so you're not going to see anything.
Yes, this is a claim derived. So
correct, and so we tried to put that clarity in the FAQs, and so just wanted to note that a lot of this really comes down to the prescriber understanding the difference between ordering an inpatient administration of the drug versus prescribing to the patient where the patient's taking the drugs home.
Yeah, and I think, again, from kind of my point of view, I think that's also a helpful bridge to look at what was the intent of the legislation.
Mm-hmm.
I know you can spend a lot of time trying to suss out what was the intent of the legislature, and then there are people who get doctorates doing nothing but studying that. But as I understand it, and I've kind of looked at it and processed it over the last 12 or so months, I don't think the intent of the legislature was to prevent people who needed opioids, particularly in an emergent setting, from having access to them. It was really to make sure we were monitoring or being diligent about safety and risk.
Exactly.
And in an inpatient setting, I think we all, as practitioners, intrinsically know that. There are some ways more hazardous settings, but there are some ways, monitoring is much closer, all the rest. So if you go back to intent, it wasn't to curtail the availability of opioids in that setting. It was to make sure we're being mindful about risk and sharing that with patients so they understood the risk.
Yes.
Okay.
That's true. And I think if you look at the Start Talking forum about, I mentioned the intent was to, at the prescriber level, to provide that education that families just were unaware of, that the patients were unaware of the risks. And then when you talk about the registering and checking of MAPs prior to prescribing a controlled substance that exceeds a 3-day supply, the intent there was to have the prescriber or the practitioner assess the patient's risk for possible substance use disorder, for doctor shopping, for a patient who's gone to multiple practitioners or multiple pharmacies to obtain the same drugs that you as a prescriber might be prescribing to that patient, and unaware.
You'd want to know about that as a prescriber, right?
Right, exactly. So
it's one of the things that bedevils us the most. We should be looking for.
And then the PA 251 of 2017 with the 7-day supply for acute pain, that limitation. The intent there was really to get prescribers to look closely at the pain and what they're treating that patient, and for acute pain, does a patient need a 30-day supply of and that could be argued, as you're a physician, so I might have just walked into something I should have said.
No, that's actually, I'd like to talk about that a little bit.
It's just more of an issue of, I think the intent was to try to reduce the volume of an opiate being prescribed, possibly post-op surgery, for example, because the rationale for that was, what happens is when you prescribe a patient such a high number of days supply that maybe they only needed 7-day or 10-day or 14-day or even 5-day or 3-day, whatever it might be. I think the practice has been that you just give a 30-day supply, and then now you've got a patient that has these opiates that are highly abused and diverted.
Yeah, they basically sit around
in their home.
Cabinets for
what do they do with the leftovers?
Right. Yeah.
Exactly.
As one of my favorite friends and colleagues, and one of the smartest orthopedic surgeons I know, and he'll appreciate that as a comment, but he said they basically just sit over somebody's toaster for half a year, and that's about what happens.
Right.
Anyway, well, if we can run to that for a second, because that's we didn't get a chance to talk about the quantity limits yet, and that's created a little bit of ambiguity in and of itself. I think it's fascinating. The part of the reason I smile is when you start talking to, and I'll both throw a tiny bit of shade at my surgical colleagues. For those of you out in the internet world, I'm a family physician by avocation and background, and not a surgeon, but work with lots of them and call them friends and all that good stuff. As I've talked to them and as they've watched and learned and accommodated to this, it's been a really interesting process for them, because when you ask that question, why do you prescribe? Traditionally it was you give somebody 30. Back in the day, it was Vicodin. Now it's Norco, whatever it was going to be when they went to the door. Why do you do that? And you just see kind of a light bulb pop. It's like, this is what I was trained to do. And it really is it's not attached to any particular science. It's not, and the science that has been done is really pretty clear. Some of it at University of Michigan Health System, where they've done some really good groundbreaking research in this, showing that the median number of doses, not days, but doses that are taken out of those prescriptions, usually somewhere in the neighborhood of 2.5. Wow. So if you give somebody 30 tablets, 28 of them are, like you said, they're just sitting around somebody's medicine cabinet and inviting diversion or overdose or all sorts of other stuff we don't want to see happen. Exactly. So, now, as I threw shade to go back to, I think surgeons have really kind of embraced this and really want to understand how to do this the right way. So I will give them a lot of credit for it. To come back to one of the other sources of heartburn, I think it would probably be helpful to have some clarity from the department and kind of understanding from a practitioner point of view. The 3-day sort of, I think, intrinsically makes sense to folks. That sort of matches up with what we see as an acute scenario. Somebody comes in with an acute injury that's really minor or ambulatory and can be treated on that basis. The 7-day, sure, that's usually in a post-op context or those kinds of things. How do we see the difference from a kind of monitoring end? How do you know what's chronic? How do you know what's acute? Because I assume the intent wasn't to prevent people from using opiates for chronic pain. I know we've got a lot of work to do on doing that more appropriately, but it wasn't to say, no, absolutely you can't do that, right?
Correct. So I think that's been, that's a question that's come up quite often that we've received from even just citizens as well as practitioners is, I'm treating chronic pain patients, or I'm a chronic pain patient myself kind of scenario, and this law is now limiting the chronic pain to 7-day supply of the opiate. No, it does not. It's just dealing with acute pain. And really what PA 251 says is, it basically says when treating acute pain, you're limited to a 7-day supply, and then it just defines what acute pain is. That's it. Okay. So there's no reference to chronic pain. I think there might have been some confusion because in some of the previous draft versions of the pending legislation before it became law did talk about a limitation on chronic pain of prescribing an opiate, but it was taken out. And so the final version was just the 7-day supply for acute pain with that definition of what is acute pain. So obviously, and we've talked about this, and I've talked about this with physicians when I've gone and traveled around the state to do presentations on not only MAPS but also these new laws, and have been joined by DHHS, and they've partnered up with us on helping to provide clarity with all these laws as well, and they've been a great partner to work with. And so, but again, with regard to really all of these laws, not just even the acute pain, but in particular for this one, when you said, transitioning from acute pain to chronic pain. So you might have a patient that, had surgery on their back and it was acute pain, you treat it for acute pain, but it progresses into chronic pain. Just use that as an example. And so our hope would be, particularly from a regulatory end, that a prescriber or the primary care physician or practitioner will note appropriately in the patient's medical chart that you can see that history that it was chronic pain but it transitioned or was acute pain and transitioned into chronic pain, and that in doing so they're able to medically justify that this is why we're treating, or we've increased the opiate, or we've changed the opiate because it's now turned into chronic pain. And so just, for the physicians that are listening and the prescribers that are listening on this LARA Live segment, document and just show the medical necessity and just note it properly. I mean, when we look at our cases that we take on from a regulatory standpoint, a lot of it comes down to the documentation.
That's a very familiar story.
Patient records, as from the board's perspective, and what you all have to review. And so it's difficult to refute something that's been medically documented.
Yeah, no, I think that's an excellent point, and to any of my past, former, present residents out there, you see why I harp on you about document, because if you didn't write it down, it didn't happen. I think, again, it's helpful to connect back to purpose on that. It's really difficult to derive intent, and what the act really expects of physicians is diligence, competence, and good moral character. And if you can demonstrate those things, if you're trying to follow the law, no one is going to. It's not going to result in a bad outcome, most likely, if you have a good rationale, as well documented, and you did the right thing. I think that's a really important point. So I appreciate that. I get into a lot of conversations with colleagues who are really very worried about this and what it means, and I think they're concerned about oversight. Mm-hmm. And I hasten to point out to them, look, the state of Michigan in toto doesn't employ enough people to monitor every single prescription. It's just not possible. So really, unless a particular incident occurs or a particular complaint is brought to the attention of the department, very unlikely, for any particular instance, but you never know which particular one is going to, you should still practice as if people are working. Right?
Correct. Yes. And again, our goal is to, when we build a case against a licensed health professional, whether they're a prescriber or whether they're, just, issues with good moral character or, some other possible violation of the public health code, our goal is to really identify the worst of the worst. And, I think in the last 2 years, we've successfully suspended roughly about 50 prescribers with, I think, a couple of dispensers, and they're over prescribers, over dispensers. But in those cases, and I think all but maybe one of the summary suspensions stuck, meaning they didn't get appealed, and the licensees actually agreed to no longer prescribe the controls and surrendered their license to the board, for example. And so in those instances, we built a case where they were overprescribing such high volumes that any good practitioner would say that is just completely unethical, doing patient harm. And physicians take pride in the oath that they've taken when they become a licensed professional, a licensed doctor, for example, in doing no harm to their patients. And it makes the whole profession look bad when you've got practitioners that are illegally prescribing with no sound medical reason to do so, and where they're actually causing death in some cases. So, but even just the impact to the individual patient, where they are feeding into their addiction, not helping them, to the impact that has with family, their family members, their loved ones around that person that's trying to help them, and then the community impact. So those are the things that we are really focused on, and not to go after the nearly 60,000 prescribers in the state of Michigan, because it's just
99.999% of whom are doing it just fine.
Correct.
On a daily
and or
basis.
want to do it correctly.
Absolutely.
I mean, there is definitely that. I mean, and I will say kudos to all, really all the health systems. I mean, we've worked with pretty much all the health systems who have contacted us, and Michigan Health and Hospital Association have been great partners, and MSMS and all the healthcare associations, MOA. They've been great in terms of wanting to understand the laws and wanting to understand, how does LARA view these, and what's LARA's focus, the department's focus, and really trying to help licensees be in compliance. And that helps us from a regulatory body, because we are limited on our resources. And the more we can get everybody to understand what does it mean to be in compliance, I think will be better for everybody. So we've gotten a couple of questions here through this LARA Live segment. So one of the questions that's come up is, does this apply to hospice with regard to the MAPS check and registering to MAPS? So that's a great question. We have gotten that question often, whether it applies to hospice, skilled nursing facility, homes for the aged, adult foster care. And so what we've done is, again, going back to the frequently asked questions, is that we have provided some clarity and made the statement that if you are ordering a controlled substance for inpatient administration, so you're administering it to the patient within those facilities, then the law does not apply in that kind of instance. One of the things that we have said, though, that the best time in those facility types to check MAPS, though, would be, and really a best practice, would be to check it when the patient or resident of the skilled nursing facility is being admitted, because it'd be no different than checking their medical record whenever you get a patient coming in to a facility to just review that MAPS, just to make sure that whatever drugs that are ordered for that patient or resident in the facility, there's not a contradiction, or they, of what they've been already receiving and so forth like that. However, hospice also is done within people's homes. I was
just going to say a large portion of this is done on an ambulatory basis.
Right, and so the challenge becomes is that it is actually being prescribed to the patient and dispensed to the patient in the patient's home, which is different than inpatient administration and ordering. And so in that essence, the MAPS check does apply. However, we are working with the Michigan Hospice Association, and we're working on some draft language to hopefully get that piece fixed, just because of the recognition of its end-of-life care, and of the recognition that you could have a patient that the prescriber may have to change the prescription so quickly.
Absolutely.
That it just, it just may not be as feasible.
It's unwieldy to check MAPS.
Correct. I mean, because it can, I've heard from hospice providers that have said, it could change within 2 hours. I mean,
which is true.
And, and I'm familiar with, I've had experience with hospice because my grandmother went in and out of hospice. God bless her. She kept hanging on, but she kept going in and out. But particularly right before she did die in her final days, I'd see the nurse changing the drug very frequently, and so that's probably one of the more unique kind of scenarios, situations, and so we're working through that issue.
Okay.
The other one was, are physicians allowed to delegate the start talking consent activities to a hospice agency? I think, again, I'm going to go back to not be so focused on the facility type, but again, the requirement of the prescriber. And so a prescriber, based on 16215, can delegate activities to a licensed or unlicensed individual, so long as that licensed or unlicensed individual is properly trained, educated, and can carry out the duties of the task being assigned. And so that would be regardless of the facility environment or clinical setting. At least is that how you would take that?
Yeah, well, if I take the question one in two ways. If you're in the context of a physician or practitioner or prescriber working within a hospice, either home-based or inpatient, I think you answered the question. Can my delegated staff, as long as they're appropriately trained and have oversight? I think the other would be if I am referring somebody to a hospice setting, if I'm managing the medications while they're in the care of a hospice agency for other things, I would take it in that context based on what I understand of the Public Act. You would still be responsible for that conversation with the patient.
Correct.
Unless you had some specific clear delegation to the folks working within that hospice and were clear line of sight into their training, their qualifications. I think it'd be taking on an awful lot of risk to delegate that to them without a really very clear, documented, written relationship. It would certainly still be permissible under the Act if you wanted to do that. Well, I can see, particularly again in some rural areas, this might be more common. It would not be uncommon, I would think, to have a primary care physician who is really the only prescriber for literally counties around or miles around, who would be responsible for maintaining those medications, and a home-based hospice staff that's primarily nurse-driven or home care aides or those kinds of folks. So I can see it in that context, and it's a really good question.
Yes, that is. That is. And then if multiple prescriptions are written, do you need a separate consent for each drug or one per patient?
Oh, that's a good question.
This is a very good question. And so we've actually responded individually because we've gotten that by email. And the way we responded it is, if you're using the Department of Health and Human Services form, which can be found on their website at michigan.gov/stop overdoses, the way that form is set up in the format of it, it does basically allow you to put in the opioid name, the dosage of that opioid, but what it doesn't include is multiple lines to put in for
Correct.
multiple.
It's a single,
So what we've said is, if you use that form, that we would recommend that you would have to do one for each drug, or we've also, and it's online too, it's the description and everything. We do note that a prescriber can use this form as a template. They don't have to use the exact form that was provided by DHHS, but they can use it as a template and turn it into an electronic form or modify it where they could add in those additional lines if they wanted to give the prescriber options in case they need to prescribe more than one.
Sure.
And set it up that way. We do note that they might want to have an attorney review whatever form they create just to make sure it meets the requirements of the law. But, there's some limitations with the current form.
Well, and I guess my answer on that one would be, don't get too caught up in the form. The form is an instrument designed to document a conversation.
Correct.
So I would say to anybody prescribing out there, if you're prescribing multiple Schedule 2 through 5 substances, you know this intrinsically, the risk goes up. It's not that it's good or bad, and it's sometimes it's very medically appropriate to do that, but you should still be having a clear conversation with the patient. Here's what I'm doing, here's why, here's what can go wrong, here's when you need to contact me, here's what you should be looking out for. So irrespective of whether it's one line or two lines or forms, it's really more about the conversation, and can you clearly document that and did you actually have it. So.
And I think the other piece that we've responded to is we've noted that each opioid, and I think the one thing is, for that form, it's just opioid based, so it's not all schedule. It may not be all schedules, so it's just anything with an opioid. And so is that each opioid agent might have different levels of risks. And so the conversation might actually be a little bit different.
That's a really good point.
So that's just something we have also mentioned in our feedback.
That's a really good point. I think we all know this intrinsically, and there's some combinations in particular that are really hazardous that I hope people would be mindful of as they're doing this.
Yep.
And just a note to all of you out there in Facebook land, please don't mix opioids and benzos. It just drives me nuts.
Yes, that is true.
I still see that.
That is true.
Very unfortunate, but anyway.
So the review, this is a common question we get, review of maps online, or do we need to print and keep a copy in the patient chart? And this is covered in our FAQs. There's actually a whole section on this. And so the answer is that once you reviewed it, you pulled the report, you reviewed it, you don't need to scan.
You just need to document that you reviewed it.
Correct. And but even if you didn't even note that, that's a good practice to note that you've reviewed it. But our response has been that our system, it has audit trails.
Well, there's metadata built in, correct?
Correct.
You know when
correct. So we
know
we know that when somebody has accessed that report, and a lot of health systems and hospital systems in particular are actually putting in the patient's record just a checkbox that they reviewed it, and so, which is great. I mean, that's an added.
That's ideal.
But one of the things that we have said is, if a practitioner decides to put that report into the patient's medical record, we have said that it cannot be accessible to any unauthorized users. It cannot be accessible to the patient, because there is a provision in the law that has to maintain confidentiality of it. And it also, the reason why, because I know we've gotten some pushback from even patients and medical practitioners about why can't they give a copy of that MAPS report to the patient. We've actually received complaints from patients that contacted the department and said, I have this MAPS report, this is my name at the top, but this isn't my date of birth. It's not me. And then, and then, unfortunately, then the practitioner is actually in violation of the law.
So it just HIPAA, so
but it's not even HIPAA, but violation of the MAPS.
No, well, actually both. If it's a different
right.
patient.
So the thing is that, and so we don't want that to happen. Number one, for the prescriber or who's innocently trying to be helpful. Certainly they can talk about it to the patient and even, review it, but just not give them a hard copy or put it in where others could access that.
Last word I'd say on that one, metadata is both your friend, but be wary of it. So know that please don't document that you looked at maps if you didn't.
Correct. Correct. Yes, that is true. Because we'll know. Because
absolutely, metadata exists.
So another really good question that's come in is, what is the role of pharmacists for keeping track of information collected from maps? So really, with regard to these laws, there's only so the mandated use and registration is actually required of the prescribers, and then there's a requirement in the law that requires dispensers, which would be your pharmacists, your veterinarians, and your prescribers who dispense in a doctor's office, are required to report the dispensation of these drugs to MAPS. And there's only one law that actually talks about a pharmacist role, which is Public Act 252 of 2017, which talks about if the federal regulations go into effect that allow for a pharmacist to do a partial fill of a Schedule II drug. But the federal regs have not gone into effect yet about the partial fill of, but it just, if it does, then they would be allowed to do so under the federal reg. But that's the only thing that was really referencing pharmacists and the role with all of these laws. And so when it comes to keeping track of the information, and I'm not sure if this question is based on their reporting requirements or based on their obligation to review MAPS before they dispense, and so best practice would be for the dispenser to review and run a MAPS report before they dispense, but currently they're not mandated to do so.
Not mandated, but what I hasten to point out, a little bit of insight from the payer side, most pharmacies, when they're in the process of processing a fill, it's all electronic. Usually the warehouses, the data warehouses they're getting data back from include national data banks. So basically it's maps on steroids. So they have claim history that they're looking at simultaneously as they look at it. So pharmacists are actually a really important part of this effort, and I cannot possibly give them enough kudos for what they are willing to do and some of the things that they've been able to detect. And, they see it from two different lenses. They see an individual patient, but they also see a community and occasionally practitioners, and really help identify where we've got some problem spots. So that's an excellent question.
Yeah, and we have gotten some questions from the Michigan Pharmacists Association, and they've been great to work with in terms of their role with a lot of these laws and implementing them. And I think one of the questions that we've gotten from pharmacies and pharmacists is what if they see a script that's 10-day supply versus of an opioid versus 7-day?
Pull the stop lever, and what do you do?
The challenge for the pharmacist is that they're limited on the amount of information that they're receiving from the prescriber or the physician. And so our response to that kind of question is the Board of Pharmacy rule does allow for a pharmacist to not fill a script if they feel that it's questionable, or if maybe they can't get a hold of the prescriber to clarify, for example. They do have that ability, just because, again, as you said, the pharmacists do play a very significant, important role, and they are the ones that really know these drugs. Really, they're trained to know all of these drugs and the possible interactions with these drugs, and the risks and dangers involved when you combine benzodiazepines with other drugs, and so they're going to be that sort of last check before that drug goes home with that patient. And so while they may not know, because that 10-day supply could actually be for chronic pain, it may not be the acute pain. It may, but for what. And so again, they have to make their best decision, just like as physicians do, based on the information that they may have available to them. But they do always have that option to not fill if that was the case.
Next.
Veterinarian vet
okay.
clinics. So veterinarians, they are defined as a prescriber and dispenser. So they've got dual roles.
Yeah.
But one of the things, if you go under the veterinarian provisions throughout their section of the code, it refers to animals as being a patient. So if you look at the code, anywhere it says patient, that means it's human. So, but for veterinary medicine, it refers to animal, and so that's not human patients. That would be an animal.
We would hope.
So no, because all of these laws refer to patients, they do not. The only exception, so in the start talking form to this, get back at the specific question, veterinarians are not required because it's strictly being applied to human patients, not animals. But the one law that does apply to the veterinary clinics would be under PA 248, the MAPS check and registration, if they are dispensing within their clinic. So, and it's not
because again, they're functioning essentially as a pharmacy.
Correct. So, but if they are prescribing where the dispensing of that drug for that animal is happening in a pharmacy, they're exempt from checking MAPS. If they are administering the drug to the animal for surgery in patient scenario,
which they sort of have,
then they would be exempt. Same kind of scenario. The only time that they would not be exempt from having to check MAPS would be is if they prescribe more than a 3-day supply of the controlled substance and they dispense it to the patient's owner right there at the clinic versus sending it to the pharmacy for pickup.
Got it.
Another question is, can we document start talking form on the day of examination, even though we would not be prescribing the medication until the day of the surgery?
I think that would be a yes.
So again, the start talking form.
It's not about the form.
Correct. Right? The start talking form has to be completed before prescribing. So even if the doctor is prescribing, here's the opioid that you're going to have post surgery, then they would have to have that conversation then, because it has to happen before prescribing.
Right. And I mean, ideally, in the way I've seen this usually applied, I mean, informed consent for surgery is usually a multi-stage process, and usually there's a conversation, other than emergent surgeries or things on an inpatient consultative basis. Usually there's a fairly lengthy discussion between surgeon and patient beforehand. Why are we wanting to do this? What are options to have that discussion? So I assume post-op pain management would be part of that discussion. Real nitty-gritty of it usually does come either immediately post-op or during intra-op. So this would make sense. Again, it gets back to intent. It's about the conversation. It's not about how many minutes beforehand. To be fair to the surgeons, and I'm guessing somebody who might be involved in the surgical practice asks this, they do live in a world that comes down to minutes and seconds.
Correct.
And sometimes what they are judged against is, when did things happen, literally based on timestamps. So it's a good question. I think it's one that it's good to bring a little clarity.
No, that's great. Yeah. And then another question that we often get, and we try to address this in the FAQs, is what does the department consider being appropriate timing of checking of MAPS before prescribing?
Can you bundle it all at the start of the year?
Right. So we wouldn't advocate that.
No, I don't think that's very effective.
But just so our answer is that we didn't want to specify within 72 hours or within 40 hours or a certain time frame, because really the best practice is before you prescribe that controlled substance. And how do you define before? Could it be a year in advance or but ideally, whenever you're treating a patient, you want to have an understanding of what's going on with that patient as close to when you're probably treating that patient. And so that's where we didn't want to get into the whole thou
must do it every 5 days.
Correct. And so we didn't want to create that sort of limitation, or
I think that's, I'm sorry to interrupt,
no,
but I think that's a really helpful message to prescribers, because there's been ambiguity going both ways. I mean, do I need, is there a frequency that I absolutely have to check this? And to me, understanding as much as I do from the regulatory environment prior to the acts and now post, there really isn't a lot of difference in the standard of care.
Right.
It was an expectation beforehand that one of the things you should be monitoring to be responsibly prescribing controlled substances. What is the rest of the fill history? What is the risk?
Right.
That didn't really change.
Right.
It's just how you document it, and the
Exactly.
requirement is there. So you should be checking it on a reasonably frequent basis,
Correct.
and it depends on how long somebody's been on that particular agent, how stable they are, how effective it is, other risks, other things that might bring it to your attention. So.
And I think probably just, to put it into context, the timing of checking of MAPs, we would recommend is close to when you're seeing that patient,
Sure.
just because it reduces that patient from thinking that, oh, well, my doctor's not going to check the system, for the next 30 days or the next 90 days or whatever. So in between, I'm going to start going to all these other practitioners
Sure.
to see, because they're not going to catch it. And so that's why we want to be very careful, because, so I think, again, reasonableness here is in common sense. And, you want to you always want to have the most current and accurate information as close to when you're going to treat that patient. And so that's how we've tried to address that. And, we'll go from there.
Makes sense. Got two really good questions left,
yes.
and it looks like we're kind of running the warning track on time. So,
are we required to check MAPs for non-opiate Schedule 4 drugs?
That's a good question.
Yes, you are.
Yes, you are. Yep.
It's for all schedules 2 to 5 controlled substances. So it's not just the opiate based. And one of the things that I should just point out and note to our listening audience is that we did have a physician contact our office and thanking the department for implementing the MAPS mandate, I guess would be the way to put it, the MAPS registration and use requirement, because this particular physician treats children for ADD, and Adderall is a common drug used to treat ADD and
a commonly diverted one.
And it's also commonly diverted.
Yeah. Yep.
And this physician, prior to the new law taking effect, had not checked MAPs, but then of course did because to be in compliance with the new law, and thanked us because he had no idea that the young patient had been receiving multiple prescriptions and Adderall. And so would never have known that if and so it wasn't a situation where the minor patient was taking all of the Adderall, but it was just unfortunate, and that's unfortunately that happens, and so but a lot of the Schedule 4 drugs are the ones that are actually more diverted and abused. So
I think it's worth reminding, particularly the prescribers in the audience. You can have a patient who's smiling, happy, seems nice, engaged, and they may be the person who's misusing or diverting. You don't really know. You can't tell by looking at them.
Exactly.
You shouldn't assume. And I think we'd also be surprised by the economic value of some of the things that we prescribe when they get outside of legal channels. And you're right. Gabapentin, for example, which a lot of us kind of regarded, or tramadol, well, those are quote safe unquote because they're not opioids. Well, no, they have a pretty high street value.
They do.
Well. So
they do. Absolutely.
That's a really good question. There's a reason we want to look at all of them.
Does the start talking form apply to all Schedule 2 to 5 drugs, or only opiates? Only opiates.
Only opioids.
So that is. Some of the laws are just opiates, and some are, and really the only one for all schedules is the MAPS check and requirement.
But nothing would stop you from using that form,
Correct.
or that.
Correct.
And again, it's about the conversation, right?
Correct.
I mean,
Correct.
you'd assume that
Correct.
anything with risk, you want to be doing appropriate informed consent with the patient or having that conversation.
Yeah. So I think our time is up. So I just wanted to say thank you for being with me and joining me for this LARA Live segment, and really appreciate it. And thank for those of you who participated via this live
Great questions. Thank
segment.
you.
Yes, thank you for all the questions. And if any of you who are listening and watching have further questions, feel free to email those questions to our MAPS team, which the email address is michigan.gov at BPL-MAPS. Or no, actually, it's the other way around. It's BPL-MAPS
I was going to correct you. Yeah.
at michigan.gov. Sorry about that. So once again, it's BPL-MAPS at michigan.gov if you have further questions.